Hi, this is Dr. Douglas Beck, and you're listening to the Hearing Matters podcast. Today's guest is Dr. Alicia Spoor, and Dr. Spoor is the audiologist and president of Designer Audiology. She completed her fourth-year externship at the Mayo Clinic in Arizona, and she earned her Doctor of Audiology degree from Gallaudet University in Washington, D.C. Dr. Spoor is a past president of the Academy of Doctors of Audiology and current Advocacy chair. She was the first recipient of ADA's Craig W. Johnson Advocacy Award, and she's the legislative chair of the Maryland Academy of Audiology. So, thank you for being here, Alicia.
My pleasure. Thank you for having me.
You bet. So I want to start, we're going to talk about the modernization of the Maryland Academy of Audiology scope of practice. Before I do that, I just want to say that one of my favorite heroes in audiology was Dr. Craig Johnson. And for you to carry on some of those responsibilities is just outstanding. He was a wonderful, wonderful guy, and he was always ahead of the curve as far as clinical protocols, professionalism, political concerns, and things like that. What an honor for you to get the Advocacy Award.
Yeah, it was a huge honor. Thanks for mentioning that. I was very fortunate to meet Dr. Johnson back when he was president of ADA, and he actually came to Gallaudet University when we instituted our white coat ceremonies back in 2003, 2004. To be able to have worked alongside of him and for him to instill in all of us that you have to give back to the profession, which means not only education in terms of the next round of audiologists, but also you have to be advocating for patients, you have to be advocating for yourself, you have to be advocating for hearing and balance. So he is greatly missed every day.
And I'll tell you one of my memories. I won't go into details. We're going to get onto the topic in a minute. But, back whenever it was 25 years ago when we were advocating for the AUD degree, Dr. David Goldstein and Leo Dorfler and me and another 20 or 30 audiologists across the country were having these meetings to try to figure out what do we do? How do we do this? All this stuff. And, every now and then Craig would call me or I'd call Craig, and I was amazed at what he knew and how well he knew it. So anyway, okay, enough about that. But what an honor. I really mean that because I knew Craig, and I didn't know him as well as I would have liked to. But from what I knew, oh my goodness, he was wonderful. All right, so listen, very recently, the Maryland Academy of Audiology has this modernization of their scope of practice, and it includes all sorts of developments that I think are new and exciting and innovative and overdue. So I wonder, why don't I just give you the floor and you tell us what happened at the Maryland Academy of Audiology with the modernization of the scope of practice?
Yeah, I'm so excited to be talking about this because, like you said, I think it is grossly overdue within our profession. I will say, on behalf of the MAA, the Maryland Academy of Audiology, we do our best to listen to our members. So each year at our convention, we talk about what initiatives do we want to put forward, what's administrative, what's legislative, what do we want to do, why do we want to do it, and how much effort do we want to put forward in this. And the catalyst for all of this was really back with the over-the-counter hearing aid legislation and the FDA's final rule coming out and saying that audiologists needed to prescribe and order prescription hearing aids. And when we went through and started making those changes to our statute and our regulations back in 2023, we were looking at our statute and regulations, and they hadn't been updated really in terms of the practice of audiology and what we could figure out for almost 20 years.
Yeah, and this is a major thing. I was president of the Missouri Academy 100 years ago, and I was involved, with the Texas Academy and California Academy 100 years ago too. People that we work with who are very, very knowledgeable about law and scope of practice and best practices. A lot of these people would say, do not open up the legislation, because when you do that, you never know how it's going to end. And if you can work within it to work on the definitions and the protocols within what exists, that's a safer route. But you guys chose the more unusual route, and you opened it up because the FDA guidelines for OTC indicated that was due.
And I hear that maybe that push back a little bit in terms of don't open it up if you don't need to, but in reality, anybody can open that scope of practice issues. So, what's preventing me as an audiologist to go in and say, well, the physical therapist can't do vestibular rehabilitation? Not that we would do that, but we could go in and put in that piece of legislation, just like any profession could come in and say, well, audiologists can't do X, Y, and Z if they wanted to. So we really wanted to take the initiative and modernize what we were doing, because our education and our training, especially in the state of Maryland and the practitioners in Maryland, overwhelmingly said, we feel confident in doing this. We feel like we can do this in safe, affordable, and accessible issues for patients. When we're in a shortage of physicians across the United States, when we have issues and they're on a 5 and 6 week wait list, that's not good for anybody.
Right.
And so our members really just wanted to move forward with this. And so we listened to them and we did.
Which is great. I mean, when you look at the World Health Organization data and you say, quality health care for citizens, the United States is ranked number 36 or 37. And not because we don't have the brightest minds or the best schools, but because of, access. And that's a major issue. Most people have insurance and they have to go where the insurer tells them to go. And you have to wait in line until it's your turn. And getting to see multiple doctors, whether it's an audiologist to an ENT to a neurotologist, or that's a very, very lengthy and expensive process. I can tell you in the military, if you have hearing loss or tinnitus and you want to get it investigated, you don't see an ENT first. You go straight to the audiologist, and that's always been very efficient, and there've been no problems with that. That's not a brand new thing. So what we know has been going on for many decades in the military, and this is thanks to Dr. Zappala, is that when an audiologist sees a patient and does a comprehensive audiometric evaluation, and when an ENT does a comprehensive otologic or otolaryngologic evaluation, they get the same result about 98% of the time. And so it's not like this is a new pathway, and it's not like it's unpaved highway. We know that this works. It's worked in the military for decades. And so it's nice to see this evolving into clinical, societal, normal day-to-day practice.
Yeah, definitely. We looked a lot at the Department of Defense, who turns out is doing many of the things that we already have, fortunately, in this piece of legislation in the VA system. And then we looked worldwide at what audiologists are doing as well. So when we just look across the pond and we look at the British Academy of Audiology, they have a lot of this already as well, too. So we want audiologists to be able to best serve their patients, and we want the patients to have accessibility and affordability and choice.
Sure.
And letting the patient choose where they go to get good quality care, and letting the audiologist work to the top of their scope of practice so that we can be a part of this medical community. And our surgeons are doing surgery, our general practitioners are triaging people where they need to go, and the audiologists can really do hearing and balance comprehensive health care.
And I think now the language that you use in the Maryland Academy of Audiology Modernization Act is evaluate, diagnose, manage, and treat. And it's very important that we use all 4 of those words across all state affiliates as we move forward.
Yeah, I couldn't agree with you more. And we are not the first state to be putting these 4 pieces of terminology in. And as you mentioned, semantics makes a big difference.
Yes, it really does.
Yeah, so Maryland already had evaluate or evaluation, and we already had diagnostics and diagnose in our regulations, but we really wanted to codify it and make sure it was written into the law on the statute side, not just the rules on the regulation side. But there were all these, like you mentioned at the beginning, there were always these little, piecemeal attempts to make sure we could manage and treat. And so we went in and followed the other 10 states that either have all 4 of these words or some of these words to make sure that we were on base with evaluate, diagnose, manage, and treat auditory and vestibular conditions.
All right. So can you tell me what are the 5 modifications or clarifications that will be enacted, I think, as of October 1st of 2024?
Definitely. You did your homework. October 1st, 2024. So I'm going to break them out into 6. And I cheated. I pulled out the language just to make sure I didn't make a mistake, even though I feel like it's ingrained in me since this has been an 8-month process. So besides the evaluate, diagnose, manage, and treat, which you talked about before, we included and codified that the practice of audiology included the conducting of healthcare screenings. We included the removal of foreign objects from the external auditory canal, the removal of cerumen from the external auditory canal, and those 2 might be grouped together. I understand why we could get 5 there. The ordering of cultures and blood work related to auditory and vestibular conditions.
Right.
The ordering and actual performing of in-office non-radiographic scanning or imaging.
Like video
And then
otoscopy and ear scanning, things like that.
correct. And then the ordering of radiographic imaging related to auditory and vestibular conditions as well. So those are the 5/6 tenets. Anybody who goes and reads it, you're actually going to see 6 legs to it because we separated.
It's so great that you did this maybe 35 years ago. Was when I taught my first cerumen removal class with
You're making us sound old. Now let's not.
I'm older than dirt. So it was about 35 years ago. I had a neurotologist and 2 general practitioner ENTs, regular ENT doctors, and we taught cerumen removal. And there was a fellow in town who thought that was quite egregious and quite literally threatened my license. He sent a letter to the state. Anyway, so the dean of the medical school was a thoracic surgeon, and my chair, I wrote letters in support of, this is what audiologists do, and it frees up our ENT residents and our ENT physicians to do surgery and do, medical consults. And it was, and then I started to think about this more and more. Well, our audiologists really trained for these things. And 42 years ago, we were doing human brain dissections. I can't tell you how many temporal bone labs I've been in drilling temporal bones, particularly when I was involved in cochlear implant research work and skull-based surgery, of course. And to think that an audiologist can't clean an ear canal, whether it's a foreign body or cerumen, and to think that an audiologist doesn't know when to order an MRI. It was 87, 88, something like that. And I saw a patient with an asymmetric sensory neural loss. And, I'd been at the House Ear Institute for 4 or 5 years and went to an amazing graduate program. And I wrote, patient complaint of asymmetric sensory neural hearing loss. Test results show exactly that. And I listed all the results. And I said, recommend MRI with gadolinium contrast. This is, again, a long time ago. But, they were freaking out. Doug, how dare you say that a patient needs an MRI? If you say that, then the physician has to order it. And you're putting their back against the wall. And it was like, did I say anything wrong? Did I do anything wrong? Did the test results not indicate that? Right? So, oh my gosh, my hat is so off to you. That's where my hair went too. But the point is, this is a long time coming. I mean, many of us have been fighting this battle forever, and I'm just delighted. So, okay, back to your story.
Yeah, no, well, and I think you bring up a couple of really good points in this too, is that when we were sitting down and drafting this with our lobbyists, our legislative team and our lobbyists got together back in October of 2023 to figure out what we were going to do after our MAA membership meeting, and the members overwhelmingly said we should move forward with looking at continuing this process. We looked at those other clinical doctoring professions, and we looked at the non-clinical providers in the state of Maryland. And so we're looking at nurse practitioners, we're looking at physician assistants, we're looking at chiropractors, podiatrists, optometrists, dentists, who I believe, as a clinical doctor, who I believe also works at the top of my scope of practice as much as I can as well, they're ordering, and some of them are performing imaging. When I go to the dentist, she does her hygienist does my x-rays.
Right.
They're ordering and doing MRIs when they go to the chiropractor. They're doing prescription medications, and Maryland was the last one to allow optometrists to be using eye drops and prescriptions. So I wanted to be at the top of the 50 states, not at the bottom of the 50 states.
And, the other one that kills me, right, is right now, audiologists are not allowed to prescribe. We do not have that legal right. And the argument that I hear all the time is, well, we don't want everybody prescribing antibiotics because then more of the bacterial issues will become resistant to antibiotics. And there's a real crisis there now because so many people have prescribed antibiotics, and I look at them and I say, who ordered those? There
right now, that was the key
one
words,
audiologist
right?
who did that, right? So but you're right. Listen, nurse practitioners, physician assistants, that's great. They're very, very valuable. They do a great job, and they can prescribe antibiotics, and they can prescribe antivirals, and they can prescribe other medicines, and that's fine. And why the heck we are not at that point? Because we all have 8 years of education, and in your case, you're still a kid, but you've got a couple of decades of experience, right? And I've got 4 decades of experience. For me to see a kid and diagnose that kid or an adult and say, gee, you have otitis, And what we're going to do is try a round of antibiotics, just like the family practitioner or the GP or the pediatrician. And you know what? There's a good chance it'll take care of that. And if it doesn't, then what we'll do is we're going to refer you to an ENT. I mean, why don't we do that? To send everybody to an ENT creates an incredible backlog, an incredible expense, and it's not more efficient and it's not safer. I would take any 4-year audiology AUD or holder and recognize that they have the same competence that the people you mentioned do. You talk about chiropractors, you talk about dentists, you talk about optometrists, you talk about podiatrists. We kind of have the same education they do. It's just that we've been held back because we've sort of been, what's a good way to say this? Kind of under the thumb of other professions. And those days have come and gone. We've had a clinical doctorate for 25 years now, and it's time to use that to the patient's best interest.
Yeah, I mean, everything you're saying is spot on, right? And for better or for worse, we are still female dominated within the profession. And I'm hoping that will change in the future as more people come in. And my patients are smart. They know where to go, who to see, and what the most efficient pathway is. And I want to make sure that they're able to make those choices without being hindered under the fact of, oh, well, I can't order that MRI for you or that CT scan. You're going to have to wait 5 weeks to see that cochlear implant surgeon, who's then just going to order it for you. And then you're going to have to wait another 2 weeks to get back on the schedule. Whereas we could speed this up in these different instances.
Yeah, we can. I think it's fair to say, no disrespect to anybody else, I don't mean to be disrespectful, but when I see an asymmetric sensorineural hearing loss that's just happened 4 weeks ago, and the patient saw their GP and they were on steroids and there's no change, and they come back to see me to get a follow-up test, I'm very comfortable ordering an MRI, because who's going to make the diagnosis? It's not going to be me. It's going to be the radiologist. And the radiologist does that whether it comes in from a chiropractor, an audiologist, an optometrist, an ENT, a neurotologist. It's the radiologist who says, here's what's going on. And so I think the responsibilities should increase to include the knowledge that we've all had for decades and the current state of practice, which is to make the diagnosis as early as possible for the practice of audiology to run in accordance with the knowledge of audiologists, right? And in all of medicine, diagnosis first, treatment second. And if we are not able to secure the diagnosis, we're just adding more time and more expense to the entire system. I don't think any audiologist, even me with 40 plus years experience, is going to look at an MRI and say to a patient, oh, look, you have a vestibular schwannoma. Not going to happen. It's going to be based on what the radiologist says, and then we're going to act appropriately, as we always have. So this is very exciting. This is the pivot point, I think, for many of us, where we say, we have this knowledge, we have this experience, we have this expertise. It puts us in the same camp as other clinical doctorates, and it's overdue. And the patients need it, and they want it, and they trust us, and we are the path of least resistance, and we're also less expensive than the other routes to acquire the same information.
Yeah, I think that brings up 2 points in
Please,
what you just said, which was fantastic, because, we focus a lot on this radiography, imaging, but it's really interesting because, as you mentioned, right, and as you read in our legislation, the radiologist is the one performing and interpreting. In reality, it's probably the radiology technician performing, the radiologist interpreting,
Sure.
And then getting the information to the audiologist to help triage or manage or treat the patient as we need to. That is really interesting, because as you were talking, the light bulb went off in my head, which is exactly what ENT is to audiology, because I know that when I send my patients to an ear, nose, and throat, or more appropriately in my area, a lot of times a neuro-otologist, because they need that level, they're not going to see that patient until they have that hearing test first. And who's performing and interpreting that hearing test before they go on? Yep.
Yeah, so you were saying that when we put all this stuff together as an audiologist and we prepare all the background, we have the diagnostics, and then we send them to the appropriate person if it's not us. most often it will be us, because there's only about 3 to 5% of all patients with hearing and listening disorders who actually have a medical disorder. And we can find them just as they do in the military, in the DoD facilities and the VA facilities. The evidence is clear that we will make the same diagnosis and the same recommendations.
Yeah, no, I greatly appreciate that. And I think if we kind of go full circle and look on the other end of the spectrum, we really want to make sure that audiologists can help our patients get to where they need to go if it's not within that hearing and vestibular arena, which is why those healthcare screenings are so important, which we've also codified. The screening side of things that became mandated for audiologists came from Medicare. They're coming from CMS, HHS around the Physician Quality Reporting Index originally back in the late 2000s, which is now the MIPS, process now. And it's to give better care. And so it's not just an audiologist doing these different screenings around medication, tobacco, BMI, health pressure. This is all of medicine.
All of medicine.
All of medicine. And so it's amazing to me that you can go to a big box store, have your blood pressure taken when you put your arm in the cuff, and have, green, yellow, or red. And it will, kind of say, if you're in these two categories, probably go see your physician. But all of a sudden, a doctor of audiology, as you mentioned, with 8 years of clinical training, can't do a pass fail, put your arm in a cuff. And it was just shocking to me.
I did an interview, must have been a year or two ago, with Robert Pfeiffer, a PhD audiologist out of Florida. And he's been on the committees that determine the CPT code for the American Medical Association. He had the ASHA chair for a while and the AAA chair for a while. So Dr. Pfeiffer did that for at least 15 or 20 years. And he would be the first one to tell you that Medicare wants all professionals to do all the screenings they can. It gets the patient to the right treatment plan more rapidly, and always treating something sooner is better than treating it later. He was very clear that Medicare wants all of us to do screenings, because the sooner you find any problem, get the patient to the right practitioner, the better it is for everybody and the less expense for Medicare.
Correct. And we in audiology say this all the time. As a private practitioner, I'm out meeting my physician colleagues, which are family, pediatric, internal medicine, oncology, nephrology, all these different providers. And I'm telling them, you need to be doing hearing screening. Related to this piece of legislation, we were really looking at not only the requirements that were coming down from Medicare for us to screen our patients, but we're looking at sometimes, especially in rural areas, or sometimes our patients are more comfortable with us as audiologists than maybe they are with their family primary, or maybe they don't have family primary care that they actively go to. We want to be able to provide that screening measure, which, as we just talked about, where we're looking at that kind of pass fail mentality, and we're looking at a group of people that might be at higher risk. And so, one of the biggest one that comes to mind is when we do vestibular evals, and that patient comes in and they're telling us their case history and story. Oftentimes we're screening for blood pressure. High blood pressure, low blood pressure. We're not diagnosing them if that screening's abnormal, but we're looking at them and saying, gosh, you have vestibular issues. That can be a comorbidity of cardiovascular issues.
Absolutely.
Your cardiovascular screening is abnormal, and you need to see a cardiologist, and we're going to get you there.
And I'll tell you, there are some people who would say, well, why is an audiologist checking blood pressure? So I got news for you. My dental hygienist checks my blood pressure before she cleans my teeth. She's been doing that for at least 10 years. In the early 80s, when I was at the House Ear Institute, long before the FDA approved cochlear implants, I used to do Snellen eye charts on patients that were cochlear implant candidates, because we know that having multiple sensory input, a sensory redundancy, makes it easier for the patient to communicate. So if a patient had a visual issue that was not detected by somebody prior to them coming in for a cochlear implant evaluation, I would take those patients and I would do a Snellen eye chart to make sure that they had good or corrected vision, right? If they didn't have 20/20 or 20/40, we would say, before we proceed, let's get your eyes checked and let's get, corrective lenses so that we can maximize your bimodal sensory input, and that's going to definitely serve you better with your cochlear implant. Listen, I don't want to get further into that, but I have a different question here.
Sure.
And I'm going to end on this because you've been very generous with your time. as far as training, I know a lot of audiologists are going to say, oh, they don't feel comfortable. And that's fine. If you haven't been trained and you're not comfortable, don't do it. And I think it's very important that there will be training classes here and there as needed to get people up to speed. But more importantly, in your own backyard, I think you have the University of Maryland and Towson. Are they up to speed on this stuff? Are their graduates ready to take the ball and run with it?
Well, I certainly hope so, because we did talk to both of those university programs when we were doing this. And as you know just as well as I do, we're not going to get a university support when we go through legislative initiatives
Right.
because the university isn't putting that through their legal review. But, we have MAA members who both work as clinical and professional didactic clinical training at those universities. And we took an in-depth dive and went through each class, each coursework, what it is, what their objectives were, what standards it met through both the AAA ACAE, AUD accreditation and the ASHA CAA accreditation, and where did it meet. And there were many things that fell under diagnose,
Yeah.
manage, treat, medical, surgical interventions. Many of them, I think both of those universities already have pharmacology classes, as you
Sure.
mentioned earlier. Now, we don't have pharmacology. We're not actively pursuing that at this point in time. They're saying that their students are getting this in their coursework. Our universities are being accredited by ASHA and or ACAE. And so I would hope that they're staying true to those members that are those AUDs that are coming
That's
out
great.
of those programs.
That's great.
And as you mentioned, right, there's continuing education for all the reasons that there's continuing education. And I think we mentioned this to you when we were chatting before too. I think every AUD program across the United States says that they do vestibular coursework.
Sure.
Does every audiologist who graduates go into vestibular right away? No. And if they change 10 years later, that is our legal and ethical requirement as healthcare providers to go back and be re-educated. You don't have to do everything we're talking about. This isn't meant for every single audiologist. This is meant for the audiologists that say, hey, I need that. I'm doing this and I want to make sure that, I'm in legal and ethical compliance with my state. Technology is going to change. We want to do 3D ear scanning, but what's after that?
Yeah,
We want to make sure we're ready.
I'm so glad you brought this up, because I'll tell you, I was in audiology when ABR became a thing. Prior to that, in 1977, 1978, Daryl Brackman and Weldon Selters, PhD in audiology, wrote one of the first articles in otolaryngology about using ABR to scan for acoustic neuromas, and their data was stellar. So I was an audiology student at that point. Pretty soon, I had to spend weeks, months, years learning about ABR from a diagnostic viewpoint. And then MRI came out, right? So, MRI has not been with us for 75 years or any such thing, nor has CT. And so these things evolved in the last 30, 40, 50 years, and they're brilliant, and it changes how you practice. But my point is that as an audiologist, already had my master's degree, I had to learn about ABR, which we did it a little bit, University of Buffalo in the late 70s. Mr. Tom White was a clinical audiologist, and he was using ABR like a Nicolay CA1000 to check children, back in the day. This is 40, 50 years ago. And, we all had to learn to do it. And it was the same with tympanograms and otoacoustic emissions and acoustic reflexes, ipsies and contras. And when you're done with your program, that doesn't mean you're done with your education. And that's the whole idea of CEUs, is as new things evolve and develop, you're responsible, if you're going to participate in those things, to have the knowledge and be signed off that you're competent in that, because the field changes. Same thing with medicine. Physicians go to educational courses all the time. So do nurses, so do dentists. Anyway, Dr. Spoor, it is a joy to speak with you. I'm so proud of you and the Maryland Academy of Audiology. I hope that you will continue in this fight, because I'm sure it's not over. But I think, audiologists need to and want to collaborate. We have the education, we have the knowledge, we have the training. And I think, as I said earlier, that the practice of audiology has to rise to meet the knowledge of audiology.
Yeah, I couldn't agree more. And as you mentioned, I hope this is a catalyst, but most importantly, I hope that this will help other states realize that, number one, you can do what we did in Maryland. Yes. Number two, there are people who are willing to help, like yourself, myself, other organizations that provided support and a lot of support in some cases to help us get this past the finish line. But that with our level of education and clinical training, we have to update these things. We can't just let it go and presume like, oh, this will be okay or somebody else will do it. So that time, talent, and treasure, everybody's got their different niche. I love doing this type of stuff. Turns out maybe Dr. Johnson rubbed off on me a little bit more on the political arena than I thought, but everybody's got their thing. So I love that people want to do research. I love that people want to do clinical work. Thank you so much for having me and for highlighting this and discussing it. And I really wish all of your listeners who are doing this in all the different states, I wish your audiology academies the best in learning how to do this and doing it successfully, and knowing that it is going to take a little time. This was not our first year doing this, but it takes a little time, and we will do it.
All right, Dr. Spoor, thank you so much for joining us at the Hearing Matters podcast. I wish you a joyful weekend, and I'm sure we'll talk soon.
Thanks so much.
Okay, take care.